scenes doing a lot of work. So welcome to the webinar on care homes and coronavirus in low and middle income countries, which is jointly organised by the Global Platform and the International Long-Term Care Policy Network. Next slide, please. As we all know, this is a very fast-changing situation, and as a result of that, we've needed to make a few last-minute changes to our lineup. So this isn't exactly as we advertised it, but this is the finalised sequence of talks in our webinar today. So in a minute, we'll be starting with Adelina Comas-Herrera, who's based at the LSE and is editor of LTC COVID, who will be talking about what insights it may be possible to take from the experiences of high-income countries and apply to low and middle-income country settings. That will be followed by Leon Geffen from the Sanson Institute for Aging in South Africa, who will be talking about how to try and improve coordination between different local government agencies to respond to coronavirus in the Western Cape of South Africa. We were then to have a talk mainly presented by João Bastos, who is based in the city of Fortaleza in the northeast of Brazil. But as we speak, he's had to attend at short notice an emergency coronavirus meeting. And so I was going to give the presentation jointly with him, along with contributions from my colleague Carla Giacomin. I'll just lead on that presentation now and use the material that they provided to me. Then we'll have two quick updates, one from Argentina with my colleague Nelly Redondo from the SIDOM Institute, and then another update from Sirafan Sasat from Chulabon Royal Academy in Thailand. So quite a lot of different papers. Most of them will be quite short, but we'll then have half an hour or so of moderated discussion. There is a Q&A link on the Zoom, so some of you will be familiar with that. There's also a chat function. Lucas will be collating those questions, and then having collated those questions, we'll return to the speakers for their responses during this moderated discussion. If you're able to stay to the very end, we'll be showing a short specially made film about a care home and coronavirus in Kerala, India, which we'll be posting on our website later today. So that's quite a busy schedule. Hopefully we'll be able to fit it all in along with some very good discussion. Next slide, please. Since we started planning this particular session about 3 weeks ago, a strange pattern has started to emerge in terms of the way this pandemic is playing out in different parts of the world. And this is an example from South Africa. And if you just look at the line chart to the left of the screen, this refers to deaths from all causes and how those vary over time. The blue line is the observed rate, and the dotted grey line is what you would normally expect at this time of year in South Africa. Basically, what this is showing is that in the last few weeks, there have been fewer deaths than expected from all causes in South Africa, be it coronavirus or other causes. So what that shows very powerfully is that, at least in terms of mortality in South Africa at the moment, the impact of the epidemic is really very small, much smaller than perhaps people would have expected a few weeks ago. Now, I'm not saying that South Africa is out of the woods, and I'm sure Leon will have some interesting points to make about this later. Next slide, please. Similarly, you may well have heard that in South Korea, the pandemic has been largely contained, although it's notable that deaths were quite limited, but about half of those deaths occurred in old age care homes. And we've got a very good blog on this written by Sawa Lee, which is available to download on our website. And I've posted the link there, which you can look at in your own time. We're going to hear about Thailand in a little bit, and here clearly the situation as well is very different to what we're seeing in Europe or North America or parts of South America. Can we go to the link, please, Lucas? So what we see here is a very limited pandemic. We're going to see a chart in a minute, hopefully. The internet is being a little bit slow.
Sorry.
That's okay.
I'm sharing the screen. I'm seeing it. You're not seeing it?
No.
Oh, okay.
But don't worry. I mean, basically, in Thailand, the peak in mortality. Oh, here we can see it now.
Sorry,
that blue line shows the peak in mortality occurred around the 22nd of March, and that to date, there have only been 54 deaths and less than 3,000 recorded cases. And it looks that the trajectory of the pandemic is gradually, with some peaks, is gradually reducing. Can we go back to the PowerPoint now, please, Lucas? So this wasn't something I was expecting 3 weeks ago. I thought we would see, a very similar pattern across different countries. And of course, it's very welcome that the pandemic is much more limited in some low and middle income countries than we might have predicted a few weeks ago. And so to try and make sense of these very different national contexts, I put together a very basic, simple framework, which might help structure some of our thinking in today's webinar. To understand what's going on in care homes in different countries, in different parts of the world, I think we need to start by looking at the general status of the pandemic across that entire population of that country, or wherever it is you're talking about, not just the people living in care homes. Then we need to look at care homes in that particular country. Now, of course, care homes are incredibly diverse in all countries, in the UK, in Argentina. There's tremendous diversity in terms of the different kinds of care homes, but there's also variations between countries in terms of the nature of the sector. And I think we need to understand those. We can then look at official government policy responses to coronavirus and also responses at a lower level, including in the care home themselves. And hopefully all of those things will help us start to make sense or start to understand what the direct and perhaps indirect initial impacts of coronavirus have been in care homes and older people living in care homes and people working in care homes in different parts of the world. So it's a very simple, basic framework, but it may help if we loosely apply that to guide some of our thinking today. Okay, next slide, please. I'm now delighted to introduce my good colleague, Adelina Comas Herrera from the London School of Economics, editor of LTC COVID, which was established just a few weeks ago and has really become one of the go-to networks providing information about coronavirus in care homes in high-income countries, but also with a much wider global remit. And I congratulate her on the massive effort that she's put into establishing this extremely important resource, along with her colleagues. So over to you, Adelina, and thank you very much.
Thank you, Peter, and thank you also for the inspiration to get all this started. So I'm very happy to be talking to you, maybe not the happiest of topics, because I'm going to talk a lot about the experience of some high-income countries in relation to COVID-19. But of course, there's plenty that we can learn from what's happened in some of the countries that have experienced the disease very early on and in very large numbers. I cannot say that what I'm going to be showing you is going to be directly applicable or useful to countries with very different contexts, but I do hope that there's some lessons that can be learned and some learning that can come across. So next slide, please. Just wanted to acknowledge that everything I will present is based on reports that a large number of experts have contributed and are going to be continuing to contribute to LTC COVID. And I'm very happy to say that we now have information for about 15 countries, but we expect to have about 25 in the next couple of weeks, including a large number of low and middle income countries. And if anybody who's here would like to contribute, please let me know. My email was in the first slide, and I'm sure that Lucas and Peter will help share my details if needed. Next slide, please. So I'm going to start just taking us through the evidence on what's happened and what do we know about mortality in care homes, and also what do we know about the symptoms of COVID-19 in care homes. Next slide. So in terms of infections and mortality in care homes, it's very difficult to get an accurate picture because the data is only available for a few countries. And then there are so many differences in the amount of testing they have done, in the policies they have in place in terms of who's targeted for testing and the approaches that they have to recording deaths. And so it's very hard to make direct international comparisons. So everything I will show you in terms of figures needs to be treated with great suspicion. It's only meant to give you an indication. And just to sort of step back to what kind of numbers we're talking about, there are three main ways of measuring deaths in relation to COVID-19. One of them is the deaths of people who test positive. That could be either before or after that death. It could be a postmortem. The other approach is to count the deaths of people who are suspected to have had COVID, and sometimes the doctor's opinion will be used for that based on symptoms. And finally, what would be the most accurate figure would be to look at the excess deaths in that period compared to the previous period. And that, of course, also tells us about the indirect deaths. So there may be some deaths that are the result of people not going to see the doctor or the hospital for some other health conditions because of this being scared or perceived lack of availability of healthcare. Or it could also be some of the effects of the lockdown measures themselves in terms of access to food, suicide, there may be all sorts of reasons. But of course, the picture is complicated. And like Peter showed in South Africa, there may be other effects in terms of reduced accidents that also affect these excess deaths figures. So it's difficult to get at the actual numbers. Next slide, please. This is the figures that we have so far in the countries that we know how many deaths there have been in care homes. And in this graph, and you can't see it very well, and that's a bit deliberate, we have a number of countries. On the left-hand side, we have the total number of deaths in the population, and these are the blue bars. And on the right-hand side, with the orange buttons, we have the share of those deaths that happened in care homes. And if you go to the next slide, here we have turned this into what we call a logarithmic scale, which is a way of reducing the apparent differences between the countries so you can get a better sense of what's happening. So basically the numbers on the left now multiply by 10 at each step. And that makes the countries look closer together, even though the origin numbers are quite different. But this is quite helpful because it's telling us that there seems to be a growing share of deaths in care homes as the numbers of deaths in the total population increase. And in here, we have shown data on Hong Kong, where there have only been 4 deaths in total, and none of them in care homes. In fact, they have not yet had any infection in any care home in Hong Kong, although they were one of the first, after China, one of the first countries to have cases of COVID. And then we have countries like Norway, where they have a relatively small number of deaths, but a really high share, about 60% in care homes. And then we have countries like Germany, where it's only about a third of deaths in care homes that are linked to, a third of all the deaths that happened in care homes. And in fact, their definition of care homes is quite wide and includes things like prisons that are not really care homes. So we have to take this data with caution, but we know that in Germany, the share of deaths that happened in care homes is much lower than in all the other high-income countries for which we have data. So this is interesting because there seems to be a trend, there seems to be a relationship, but it means that I think there's something that we can do. So next slide. So what we've learned so far from this very limited and messy data is that although we have this relationship between higher number of deaths in the total population and a higher share happening in care homes, there are exceptions. And these exceptions are telling us that there's something we can do, that having a large number of deaths in care homes is not inevitable. Next slide. There's another thing we've been learning from early epidemiological data in care homes, and that is that symptoms are not a reliable predictor of infections in older population. So there are some studies in the US that show that about 50% of people with COVID-19 infections in care homes had no symptoms at the time, or were perhaps pre-symptomatic at the time they were tested. Data from Belgium shows that 73% of staff in care homes and 69% of residents who tested positive had no symptoms. And that's telling us that any guidance that's based on the typical symptoms of cough and fever is not going to help us very much in terms of isolating and identifying the people who are likely to have COVID-19. And we also now have growing evidence from geriatricians that people in care homes quite often have what they call atypical symptoms. Next slide. And this is from a blog post on the British Geriatric Society, where a geriatrician was basically doing a survey on Twitter of other geriatricians in terms of what were the symptoms they were identifying And what they were saying is that they were noticing that the main symptom was delirium, both hypo and hyperactive, diarrhea, lethargy, falls, reduced appetite, and that fever, cough, and breathlessness were actually quite uncommon. So it's very important that when we look at the guidance for the general population, that we make sure that when we're then applying that to care homes, we're aware of these really important differences in the population that we have living in care homes. Next slide. And now that taking you through the little that we know so far about the impact and type of symptoms presentations, I'm going to take you through examples of measures to prevent and manage infections in care homes. I've listed the countries on which this is based. They're all high-income countries, and I appreciate that some of these may or may not be relevant in your context. All of this information comes from reports published at LTC COVID. I've put in the link there, and it's all publicly available, and these reports are regularly updated and all written by experts on long-term care. Next slide. So I'm going to distinguish between three types of measures: the measures to support care homes to prepare for the pandemic, for the outbreaks, measures to prevent the infections from entering a care home, and measures to control and manage infection. Next slide. In terms of, and I've actually called it a policy in terms of supporting care homes to prepare for outbreaks. One interesting issue that's, for example, something that's happened in Israel is that the care homes were dependent on 3 different ministries. And it was very difficult for them to act and to get together and have a plan of action for care homes. So they ended up establishing a national task force to coordinate the response. They did that around mid-April. And this is very helpful also in countries where you have involvement of the national and local level and sometimes regional level in managing care homes or in regulating and supporting care homes. So it's very important to establish a coordination center. It's very important also that this task force or coordination group center has representatives from relevant bodies, including relevant expertise, which may be geriatricians, people, experts on dementia, which is quite often a large share of the residents in care homes, and experts in running care homes. And it's very important that there's a very clear link and a very good coordination between the response in care homes and the response at population level and hospitals. You cannot separate them. They have to be considered together. It's very important as well to establish information systems to monitor outbreaks in care homes, and then to link these care homes that have outbreaks to supplies of personal protection equipment, potentially additional staff and medication. Next slide. Very important to develop up-to-date guidance and to make sure that this is really reflecting the evidence, for example, in terms of symptoms, and to deliver training on implementing the guidance to all care home staff. Very useful also, I think in many countries, it has been to prepare rapid response teams that can be sent to homes that may become overwhelmed if they have a large number of infection and a large number of staff not able to work. We've seen countries that have implemented measures to reduce care home occupancy where possible, to make it easy to then have physical isolation if needed. And again, very important to ensure that care homes are supported in assessing how feasible it is to establish isolation in their current buildings. Not all these care homes were not designed to be isolation centers. And quite often people will be very close together. In many countries, you will have people sharing rooms. And if one of them has COVID, the other doesn't. What's a recipe for disaster? So it's really a case of understanding what can realistically a care home do within the existing infrastructure that they have. Next slide. Now going to go very quickly through these, but the slides, of course, can be shared. And we're about to publish a report going into a bit more detail on all these measures. We're going, in terms of what can you do to prevent infections in care homes, there are obviously 3 main ways in which the infection can enter. These may be from visitors. So most countries have banned visitors, maybe with some exceptions for compassionate grounds. But I think now as the time passes on, it's also clear that we may need to move to some different approaches, perhaps looking at how to make visiting safer. The other route of infection would be from the staff coming into work, bringing the infection with them. And there's some things that countries have done. Some of them is to ensure that staff only work in one home, and ideally even in one section of the care home, if it's a large care home, ensuring that staff has sick pay so they don't feel they have to continue working when they're unwell and have symptoms. and that in the US, for example, was a big problem. Sometimes offering alternative accommodation to staff so they can sort of self-isolate and continue working, and they don't maybe bring in virus from other settings. And in some cases, staff may want to move into the care home and just live there, so there's not coming and going. And that obviously needs to be considered carefully. Then there's, of course, measures to ensure that new or returning residents don't bring infection, and they're important to be very careful with hospital discharges, especially where people have had the disease and may be positive. And many countries have used alternative quarantine centers so that people can be in isolation before they go into the care home. And many countries have policies to isolate and test all new residents. Next slide. In terms of how to monitor for potential infections, because of this problem with asymptomatic transmission and the fact that older people don't always have what we call the typical symptoms, regular testing of care home residents and staff is extremely important. And then we can use that to do contact tracing and identify who people have been in contact with and isolate correspondingly. Very important again to also keep doing, because we may not be able to get the testing quite as often as we'd like, to continue with symptom assessment and making sure staff are trained in recognizing geriatric symptoms of COVID. Next slide. And then once you happen to have the infection in, what can you do? So you will want to be doing extensive testing, contact tracing, who has this person who is positive, been in contact with which members of staff, which residents, and all those who have been in touch, ideally should be in preventative isolation, just in case. Continue with regular symptom monitoring. We can, if feasible, then you could have isolation within the facility, but you may want to, if you can't, and especially if you have shared rooms, you may want to look into outside the facilities, whether some other places can be converted into quarantine centers. Some countries will already have quarantine centers established. It's important to think whether care home residents may be able to move there. And another approach is to, and especially if you have a suitable home, is to divide the care home into risk zones and then staff only working one of the zones, and there are very clear processes to keep them separate and to make sure that the disease doesn't spread through the care home. Next slide. A challenge is that once you have the infection in, you have people who basically are very ill, and you need to make sure that you have access to healthcare support to deal with that. And quite often the staff will not have the medical training that this new situation requires. And there's different things that can be done. Some of it is to try to use telehealth for visits from healthcare providers. You may be able to, in some countries, what they've done is to transfer care homes to the health system and to be under the responsibility of the health system temporarily to deal with infections specifically, and ensure that then all the resources can flow through from the health system into the care homes. You may be able to deploy additional healthcare staff to treat people with infection, and also to provide palliative care to those for whom treatment is not really feasible. And consider updating advanced directives to understand whether people want to have more invasive treatments or not. And finally, of course, to continue to ensure an adequate supply of medicines and equipment. It tends to be a very challenging issue. We've seen this in all the countries that have experiences. That high-income countries have had huge difficulties accessing PPE and even medicines to deal with this. So obviously, the better prepared you can be, the better. Next slide. And what do we do about staff? Staff are going to be under a huge amount of stress. It's very important to also consider that a large number of them may have to self-isolate, so that gives the facility short-staffed. So it's very important if you can deploy rapid response teams to support care homes who have large outbreaks and need additional support. In many countries, they're now paying additional money to carers and giving them additional benefits to compensate for the large number of hours they're having to work and all the changes they're experiencing. In many countries, they're also removing limits on the number of hours that staff can work. Many countries are also facilitating accommodation or even providing it within the home so that staff don't have to travel in and out. and don't fear taking the disease to their families, because of course for many of them this will be a large concern. They may have all the relatives living in their household that they fear they will be passing the infection on. Quite a few countries have deployed the army or the fire service to support care homes with disinfection. And we're now beginning to see some tools to provide psychological support to staff who are experiencing trauma as a result of the very stressful situations they're encountering. Next slide. We also have an issue, which is that care home residents are suddenly living in a completely different way. Many of them will have dementia, will not necessarily understand why they're no longer receiving visits from their families and why they're no longer having any group activities and they're locked in their rooms. And we have seen a number of ways in which this has been tried to be compensated. Some of them is through the use of technology to facilitate virtual contact, window visits, and of course, there's quite a lot of examples now, and we're trying to and it's quite out on the web available in terms of alternative activities that are compatible with physical distancing. And I'd like to end with the next slide, which I thought was absolutely beautiful and showing that love can get through even through a window if you're able to have that. So that's my presentation. Thank you very much.
Thank you so much, Adelina. And that final image is really special. And it reminds me of about a week ago when I was singing happy birthday to my mother across the gateway to the sheltered housing in which she lives. So yeah, we're all clearly affected by this in different ways. Clearly, you know, it's been a huge challenge for high-income countries to deal with this issue. And as Adelina set out, there's so many different issues in a sector that has been traditionally neglected for decades in most high-income countries. And so I know that some questions have been coming through. You know, there were lots of interesting things to follow up on. We'll be taking them in the discussion session after we've had all of the papers delivered. So please do send in your chats to Lucas, who will be collecting those questions. Now I would like to hand over to my good colleague and friend, Leon Geffen, who's a director of the Samson Institute for Aging Research in South Africa. And he's going to talk about his tremendous frustration in trying to bring together different local government departments for a coordinated response to coronavirus in care homes. And I think this is something that many of us will be familiar with, this disconnect between agencies which are focused on health and agencies which are focused on social services or social welfare departments, which have struggled in the past to work together. And now clearly there's a desperate need for them to find ways to overcome those divisions. So over to you, Leon.
Peter, thank you very much, and happy Workers' Day to everyone if you're celebrating Workers' Day, or but happy May Day, whatever we're calling it today these days. I wish I could tell you a good story. I wish I could come to you and say, I don't have a PowerPoint presentation. I did prepare a PowerPoint presentation based around the fact that I knew there was supposed to be a meeting between the Department of Health and Department of Social Development in the Western Cape province in which I reside today. And I was going to give you the good news story that there was going to be sharing of PPE, that there was going to be coordination of services, that there was going to be testing strategies put in place, that social development and the health departments were going to be working together. Unfortunately, that slide pack that I've put together is non-existent and is not going to be shown to you because it's not happened. And anything I would have put together would have been fake news under the circumstances. So I am going to tell you our processes leading up to now, and share with you, as Peter said, the frustrations, and then also how, in the absence of leadership from certain government agencies and departments, how the local organizations themselves are taking it upon themselves to take the lead in the situation. So to understand where we're at in South Africa, well, just to say at the moment, there's just over 5,640 cases of coronavirus in the country. We've been under lockdown since the 27th of March, sorry. And just today have moved from what's called a level 5 to a level 4, where there's been a slight lifting of services. So for instance, between 6 o'clock and 9 a.m. this morning, people could go out and exercise, and they weren't allowed to exercise in groups, but I don't think that was really adhered to. We've had 103 deaths in the country so far, and just in the last 10 days, I'm very pleased to see that there are a number of colleagues of mine from Cape Town on the in this webinar. We've just seen a smattering of coronavirus now starting to rear its head in care facilities. So South Africa is a middle-income country, and the care of older people in residential care facilities or nursing homes, we call them residential care facilities in South Africa, is governed by what's called the South African Older Persons Act. It's an act that was promulgated in 2006. And there were regulations published in 2010 about for the act and for how people were going to implement the act. And that is an act that falls under the ambit or the control of the Department of Social Development. The Department of Social Development is a national competence. In other words, that provincial departments have very little control over their budget and over what happens at a provincial level, as opposed to the Department of Health, which is a slightly more devolved department where local departments of health belonging to the provinces are able to set their own budgets within limits and actually able to set their own targets and as to what they want to achieve in terms of the health. And with these two departments, the Department of Social Development being responsible for older persons and the Department of Health being responsible for the health of the population of the province, residents who live in care homes actually tend to fall between the cracks. And it's become a major problem. Now, the Older Persons Act regulates the registration and establishment and the management of the services and the establishment of the residential facilities for older persons. They're supposed to have developed things like registers for caregivers, training programs, and established the framework for training of caregivers, and a whole lot of issues around provision of care to residents of care facilities. But it's 10 years now after the promulgation of the regulations, and if you had to phone the Department of Social Development and ask them to give you a core curriculum, I don't think you would be able to find one. And if you had to ask them for a register of care workers who should be registered under them, I don't think you'd be able to find them either. The care facilities are registered in under three categories. There's category A, which is called an independent living facility, category B, which is an assisted living facility, and category C, which is frail care. And it's important to understand this because it's only really the frail care residents who do get funded in facilities. So when we're living in a country that's a low-income country or a middle-income country like South Africa, if you fall into the first two categories of either being independent and living in a care facility or in an assisted living category, there is no funding to the facility for that individual. Only people who fall into the category of frail will get funded. And in our province, the Western Cape province, there's about 6 million people, of whom about 10% are over the age of 60. And in South Africa, Older Persons Act defines an older person as a person over the age of 60, about 600,000 people. There's 117 what's called funded facilities. These are facilities that provide services to the lower socioeconomic groups of people who cannot otherwise afford private care facilities. And these 117 facilities are registered for about just over 9,300 people, and approximately 5,000 people in these facilities are funded. And why it's important to raise this issue is to say that the facilities are not funded, but the people living in the facilities are funded. So it becomes incredibly difficult for facilities to budget going forward how they need to provide services and everything that needs to be provided in terms of care for residents, because they're not sure from one month to the next how many residents they're going to have who are funded by the Department of Social Development. And particularly now, during the coronavirus epidemic, if there are going to be a significant number of deaths from residents living in care facilities, and as Adelina pointed out, we could expect a case fatality rate, assuming the coronavirus gets into the facilities, of anything from 25 to 50%. And we could expect about around about 1,000 deaths within the population in the Western Cape of residents in these facilities. And that will have a very significant impact not only on the social fabric of the facilities, but on the income that facilities would be wishing to receive from the Department of Social Development to keep them going. Well before the lockdown, many of the facilities, so the lockdown happened in South Africa on the 27th of March, well before the lockdown, and this is facilities of their own making decided to go into lockdown. It became very apparent as what was happening in Italy and then in Spain, what was happening with regards to older persons, and facilities of their own volition decided to go into lockdown. All the measures that Adelina raised in terms of active screening of people coming into the homes was implemented by many facilities. Temperatures being taken, all visits from family members were basically put to a halt. So many of the facilities have now been in strict lockdown for up to 6 weeks. There's been screening of residents for symptoms. There's been screening of all caregivers and all support workers coming into facilities. All of this has been taken up by the individual facilities or grouped together, people working together to make decisions about this. None of it under the direction or directives of the Department of Social Development. When it came to protecting staff, so these are the issues, the items that have been put into place to try and protect residents. When it came to protecting staff, there's been a lot of discussion around provision of PPE. And the Department of Health is not going to provide PPE to staff. This is what I was informed late yesterday afternoon and reaffirmed this morning, because as I say, it was part of what I was hoping to discuss with you today, to say, well, there's been a coordinated response between social development and health to say that PPE would be provided to care workers. Well, this is not going to happen. The Department of Social Development is supposed to provide the PPE according to the Department of Health. Department of Social Development, as far as I know, has told us that there is no budget available for this. So staff are not going to be getting PPE at this point from Department of Health nor from Social Development. And this is a significant problem. This is going to lead to possibly widespread staff refusal to come to work, and obviously diminishing and deterioration of services that have to be rendered. And then we start talking about issues around, well, how do many residents in the low income facilities are cohabiting with maybe 2 or 4 to a room. Facilities have tried to keep social distancing amongst residents, but this is virtually impossible to do. And if we do have an outbreak in a facility, as we started to have now in Cape Town, how do facilities which are fairly full having to find places to keep residents separate from one another, or to find individual spaces within the facilities? Once again, having reached out to Social Development and Department of Health to say, is there any way that you can come up with individual facilities that we could, or boarding houses, hotels that were previously full but are now completely empty, to quarantine or isolate care workers or residents who are positive? And that's not come to fruition yet. And how do we continue maintaining services when we are going to see up to 25% of care workers in facilities becoming positive with coronavirus and having to go into quarantine themselves, and having to and then trying to find outsourced service staff to come and provide services for people? And once again, Department of Social Development don't have a register of care workers who we can call on as a ready source of care workers to provide services to them. The funding that's available for a resident, and just to put it into perspective, and maybe for many of the lower income countries, this sounds like a very, very luxurious situation to be in. But in South Africa, the older person grant is just around 1,800 Rand a month, which is in US dollar terms, $90 a month. If you are in a frail case, if you're deemed to be frail, then the Department of Social Development augments the income to the facility for that individual of about 3,540 Rand a month, which is around about $170. So effectively, facilities are providing care to residents on about $180 a month. And for that, people are getting food, they're getting care services, and they're getting their laundry and all the domiciliary service that one would require for them. The Department of Health has started now engaging with the sector and has been engaging with the sector for quite some time. The Department of Health has put into place an active screening program now for residents in care facilities. They've recommended screening of all care workers coming into facilities. However, we know, and the evidence has just come out, that many people are walking around asymptomatic, spreading the virus. There was the paper that Adelina alluded to that was published last Saturday in the New England Journal of Medicine, that 50% of people in a care facility were asymptomatic for 5 days until they showed positive symptoms. And in that time, they were shedding exactly the same amount of virus as the symptomatic people. The Department of Health is not going to be providing PPE to the staff, and there's going to be no alternative accommodation provided for people who are positive. So I wish I could tell you a good story, but I can't. With the lockdown, the intention of the government was, how could we mitigate the spread of COVID? And I think they've done an exceptional job, that we've only had 5,647 cases. There've been many hundreds of thousands of people screened, and I think our total number of tested individuals is just around 100,000 at this point. So I think the government is under very trying circumstances at a national level, and the National Command Centre is doing a great job in terms of communication, in terms of informing the public, in terms of maintaining the lockdown. Obviously, there's going to be massive socioeconomic effects on the population from this. Already we're hearing stories of hunger and starvation. There could be social unrest. However, one of the things was also to prepare the country for COVID. And at a tertiary and secondary level healthcare services, yes, there is preparation. Ventilators are being put into place and acute care beds are being separated. But there's no central coordination between health and social development, who are supposed to deliver these services to people on the ground. And at the end of the day, it's the care workers, it's the managers of the staff, the frontline workers who are the ones who are going to suffer the most from this. So we can say that intersectoral collaboration at the moment is a pie in the sky. There'd been no intersectoral collaboration prior to COVID-19. We do hope that post-COVID, this is one of the learnings that we will get from this, from COVID, that we will start improving intersectoral collaboration. And having said that, what we've known is that the sector itself has taken up the cudgels. We've got people who are working in community-based organizations, providing services to people living in the community, residential care facilities, all talking to one another, sharing resources, sharing ideas on how we can try and prevent this. And basically what we've got is we've got civil society organizations and service providers putting their minds together and putting their own leadership together. We are learning by trial and error. Lots of information is being shared. And the question I'm putting out there, does it require social activism to get government to start acting together? And is it going to require legal intervention to force the government to start working together? And that's where we're at the moment. And as I say, I wish I had a positive story to tell you about intersectoral collaboration at a national and provincial level. But at this point, it seems like political boundaries are incredibly difficult to cross. And at the moment, people are still operating in silos, all to the detriment of the people that we wish to provide care to. So thank you for that.
Thank you so much, Leon. And I think we all share your pain and your frustration. And clearly intersectorality, I was going to say it's easy to say, but hard to do, but it's actually quite hard to say as well. And I think this is a problem that is being repeated all around the world, that the previous lack of coordination between different government departments, one would hope, would be broken down in the context of this crisis, but that's a lot easier said than done. But maybe as things move forward, that can be improved, and there could be a positive legacy if we start finding new ways of really developing a more coordinated process of managing the sector. Again, we'll collect questions and comments, and they're coming in, and we'll work those into our discussion session towards the end of the webinar. The next paper was going to be looking at Brazil, and was going to be mainly presented by my good colleague from Fortaleza, João Bastos. João is actually, and this is good news for Leon, he is attending an emergency meeting of the local health and social assistance departments in the city of Fortaleza, Brazil, who are actually cooperating quite well. And there are 2 or 3 local governments in Brazil, not many, where they do seem to be getting it together in terms of collaboration between health and social agencies. The presentation also draws on contributions from my colleague Carla Giacomin, who I'm going to talk about in a minute. Carla's currently in a part of Brazil where the internet connectivity isn't very good. So again, she said, could I just give the presentation on the group's behalf? So following that framework that I set out earlier today, earlier in the webinar, we can see that the pandemic has been progressing at a much, much more alarming rate in Brazil than in many other low and middle income countries. 87,000 confirmed cases to date, of course, many more, and at least 6,000 deaths that have been attributed to coronavirus. And the pandemic is growing very rapidly over time. Just in the last few weeks, we've seen a tremendous acceleration. So a very worrying scenario in terms of the general shape of the pandemic. In terms of the sector, in terms of residential long-term care in Brazil, in some ways there are quite a few similarities with the observations that Leon was making about South Africa. But one thing that you see across most of Latin America is that a significant proportion of older people who live in residential long-term care have very low levels of dependency, or actually completely independent. They have no functional limitations. And it would seem that many of these institutions seem to serve more as shelters for older people who have nowhere else to go than a place which is providing special services for people with particular needs. And I think that's quite an unusual characteristic. And we are talking here not about 5%, but in many cases, you can see 30 or 40% of residents that would fall into that category. There's tremendous diversity within Brazil in terms of the kinds of nursing homes and care facilities that you see. Typically, again, you see room sharing, as Leon was talking about in South Africa. Typically, resources are quite limited, but Brazil, like South Africa, is a country with tremendous inequalities. And you can also see some wonderful high-end, very luxurious care homes for those people who can afford them. Increasingly, in Brazil, as in many parts of Latin America, there are large numbers of care homes which are completely unregistered, unregulated, and about whom it's very, very difficult to capture information. And of course, this is going to be a massive challenge, because these will be the care homes which are likely to be particularly vulnerable to the effects of this pandemic. And even for care homes, which are under the official radar one way or another, regulation and quality control have been traditionally very, very weak. Even basic information about these care homes is very limited and incomplete. So that's a very broad brushstroke sort of picture of what residential long-term care looks like in Brazil. In terms of responses, firstly at the national level, at the federal level, a lot has been going on. Including some, I think, very technically complete, excellent guidance for care homes, which has been the result of a very impressive, very rapid interaction between a very large number of experts. So next slide, please. So this was published just a few days ago in Brazil, and are the national guidelines for long-term care facilities. And this has been supported by the Brazilian Society of Geriatrics and Gerontology, by the Federal Ministry of Health, and by a number of other organizations, including the National Association of Public Health. Next slide, please. I just want to point this out to you. sorry that this is such a busy and detailed slide with lots of small writing on it, but what this shows you is that, this is from the inside of the report, that this report was put together by 9 different groups. I've only been able to fit 5 of them onto this slide. And each of these groups had responsibility for a particular area of work, and they brought together a dozen or more different individuals, experts from different parts of Brazil. So you might just be able to see in brackets those 2 letters refer to different Brazilian states. So what this shows to me, and this was led by my colleague Carla Giacomin, who you can understand has been incredibly busy, and this was a Herculean effort to bring together all of these contributions and individuals into a coherent document. What this shows about Brazil is something that you probably wouldn't see anywhere else in Latin America, and probably not in many other countries anywhere in the world, which is the number and the strength of people and networks who have expertise in this area. And many of these individuals are not just academics, they also have links to government agencies. And some of them are also practicing geriatricians and involved in running care homes. So this has been, on one level, I think, a very impressive response. The fact that it's been possible to bring these people together and agree to these guidelines so quickly. Of course, Brazil isn't just an unequal country, it's a very large and diverse country geographically. So now what I want to do is focus on one particular part of Brazil. Next slide, please. The city of Fortaleza. So Fortaleza is quite a large city located in the northeast of Brazil. The northeast is a part of Brazil which is much poorer than many other parts of the country. And this photograph is my good friend and colleague João Bastos, and we've been working together on a project for a number of years in Fortaleza and in other parts of Brazil about trying to bring together health and social care agencies to improve community services for older people. João is quite typical of this amazing group of people who exist in Brazil who contributed to that report. He used to be the president of the Brazilian Society of Geriatrics and Gerontology. He's a practicing geriatrician, and he's also head of older people's health for the local municipality. So he brings together all of these areas of expertise and influence. At the end of March, João was infected with coronavirus and was quite ill for a number of days. I'm glad to say he threw it off. And in early April, he was working incredibly hard to try and prepare his city for this pandemic. And one of the first things he did was to persuade the Departments of Health and Social Assistance to conduct a simple survey based on a very short questionnaire of all the care homes that they knew about in the city to evaluate their level of risk and how far they were already prepared to deal with the coronavirus pandemic. Next slide, please. Thanks. So I'm just going to present a couple of the results from this survey. This refers to a question about I've lost my notes now. Are you experiencing difficulties accessing medication that you need on a daily basis for your residents? And of the 17 homes that participated in this, 13 said yes and 4 said no. This was survey was conducted 2 weeks ago. I suspect the situation may have deteriorated since then. Next slide, please. This was asking whether they had been able to start developing plans so that they would be able to check both staff and visitors and residents for suspicious symptoms such as a high temperature. And quite positively, 16 out of 17 care homes claimed, maybe they didn't, but they claimed at least that they would be able to do this. One of them said it could not. And I want to highlight that particular care home because that care home answered negatively to a range of different questions about preparation, access to equipment, nutrition of residents. And what that meant was that they were able to offer specific support targeted to that particular care home. So one use of the survey was that it enabled the joint health and social care departments to provide particular support for that department, for that care home, I'm sorry. I spoke with Jean earlier this morning, and he told me that the situation currently in Fortaleza is that there have been 10 cases of coronavirus, reported cases in care homes, and there have been 2 deaths in care homes. I asked him about the situation in Brazil as a whole, and he said nobody has any idea how many cases and how many deaths are occurring in care homes across Brazil. So despite this wonderful network of experts and practitioners who've been able to develop this guidance, we have very little knowledge about what's happening on the ground. So that's my presentation about Brazil. I'm now going to, next slide, please. Normally I don't talk very much in these sessions, but things have played out slightly strangely this week. We're now going to present a short update about the situation in Argentina. This has been largely prepared by my colleague Nélida Redondo, who is here in the seminar. Nélida speaks quite good English, but isn't very confident about giving a presentation entirely in English. So I am basically going to be her glove puppet. I'm going to be her voice. And I'm going to make some general observations from the presentation we developed together. But I'm going to bring in Nélida to illustrate a number of specific points that I think are of particular interest. So the pandemic in Argentina has been less ferocious to date than in Brazil. There have been about 4,500 reported cases, about 200 deaths attributed to coronavirus. And if you look at the pandemic curve, there is a rise over time, but it's quite a bumpy rise with peaks and troughs. That may have a lot to do with irregular reporting of deaths and data issues in Argentina. I put up a hyperlink here for a study that Nélida and I worked on, which provided a lot of information about the nature of residential care services in Argentina. Just a couple of points. One is that there are an awful lot of residential care homes in Argentina. 10 years ago, the National Association of Care Providers estimated that there were over 6,000 residential care facilities in Argentina. That was 10 years ago. The number will have gone up since then. And that didn't include the many unregistered illegal underground care homes, which we see in Brazil, Argentina, South Africa, and many other countries. As a generalization, there is very little regulation, even of the officially registered care homes, and access to information about those care homes is extremely limited. Information, if you want to find out about the services being provided by a care home, perhaps but for a family member who may need their services, it's extremely difficult to find out what's available. As a result of our research that we did looking at the sector, Nélida led a very interesting local initiative in the Argentine city of La Plata. And Lucas, if you can go to the hyperlink, I'm going to hand over to Nélida. This is the website for this intervention. It's in Spanish, but Nélida is just going to spend a minute or so outlining what this intervention is about and why it may offer some particular value in terms of dealing with coronavirus in settings of weak governance and limited information. Lucas, at the moment we can see Leon's slide, but we can't see the website for Red Mayor.
Okay, I'm sharing
yes.
it now.
Yeah.
Here it is. Okay, Nélida, over to you.
Yes. Well, I thank you, Peter. Well, I want to introduce Red Mayor. Red Mayor is a civil organization of all the persons in La Plata City, which is the capital city of the most important province in Argentina, which is Buenos Aires province. And we carry out research work with Peter and UEA in La Plata in 1216. And from the findings of this research work, we try to develop this web page like a TripAdvisor style, where we list all the institutions which are registered by the Minister of Health in La Plata. Here is, and we put in contact of the population in La Plata in order to invite them to bring their opinions or comments about these institutions. We don't publish these comments, but we have, and we try to put the comments with the governmental authorities. In this moment, we are trying, and we started a quick survey, just the model of Brazil experience, and we are working together, Red Major with Sidon Foundation, and with the organization of owners of the geriatrics in Buenos Aires province. They are interested in have data about what is the situation of the nursing homes in the province to cope with the pandemic. And well, we started, and we are following a strategy that the interview asked to the owner of a geriatric to recommend other colleagues in order to making a larger list of nursing homes located in the city and in the neighborhood of La Plata, and people are interested in receive support. And we are when we have finished the survey, we are trying to contact to the government, local government, city La Plata government, and province of Buenos Aires government, in order to ask, focus on the needs of the geriatricos. And of course, the civil society, in order to together bring a response to, and people is concerned. People well received this initiative.
Thank you so much, Nelida. Lucas, can we go back to the PowerPoint, please? So basically, this is an initiative which has provided certain amounts of information to the public of Argentine city of La Plata about care homes which are operating in that city. And it's been running for about a year, and it's been quite popular and effective. And now what Nelida and her colleagues in Argentina have done is, firstly, they're providing information about coronavirus and care homes in that city on the platform, but they're also using that to support a more general survey of care home preparedness, a bit like my colleague João Bastos did in Fortaleza, not just in that particular city, but in the whole of the province of Buenos Aires, where there are several thousand care homes, and many of them are very informal, with large amounts of overcrowding and very scarce resources. So Lucas, would you mind just going back to the previous slide on Argentina? Thanks. And so, for example, if you can just click on this form at the bottom, this is just an example of a very simple questionnaire that Nelida and others developed, and are now using Google Forms to administer this questionnaire across care homes. And there's a lot of interest in higher levels of government in Argentina, just to obtain some basic information. Lucas, can you screen down that, or it's not possible? But just a few very simple questions about how prepared they are and what concerns they have. And in the context of many parts of Latin America, this information isn't widely available for government departments. And so it's an essential first step to enable some kind of emergency strategy to deal with the pandemic in care homes. Nella, did you want to add anything else?
Well, we are trying to inspire other local governments to carry out these kind of projects in their localities. Yes, we are trying to expand the experience.
Thank you. Can we go back to the main slideshow again now, please, Lucas? And we'll move on to our second national presentation, which refers to the situation in Thailand. And this will be given by my good colleague, Siripan Sasat. And Siripan, do you want to lead on the presentation, or do you want me to lead on the presentation? I'm happy either way.
Right, I can lead.
Fine, okay, I'll stay quiet.
Right, thanks very much, Peter, for the invitation. So this is a little note from Thailand, as you have already introduced about Thailand, what happened in Thailand. So we have very limited progressions of the pandemic. To date, we have only 6 new cases, no new death. So the overall, Thailand had 2,960 cases with 54 deaths. So it's pretty low to compare to other countries. The emergency act will be extended for another 30 days. And however, from tomorrow, the public park, hair salon, a fresh market, food store, convenience store will be reopened from tomorrow onward. For the natures of the sector, the majorities of care homes are relatively small, but fast growing. According to the remedies of public provision, that is why we have more private sector rather than public sector. The finding from our small scale study about informal home in Bangkok in 2018, one of our participants said that there are thousands of them. You can find them on every corner of Bangkok. They advertise all over the place. So there is still limited regulations due to there is no registration system available at the moment. But the regulations has already been drafted and waiting for the approval from the government. Next slide.
Next slide, please, Lucas.
Right. We've been in contact about 6 care homes in the past few days. The owner of the care home quite worried and anxious because they have received no official support from the government. They mentioned that they have lack of PPE and other important equipment, and they are not confident that they can follow the regulation, the guidance that they have seen from the source such as Health Age International, from Japan, and from WHO. Some of them said that the guidance need to be adapted into the Thai context. For example, they have only small space in the small care home, so it's quite difficult for them to quarantine to the isolate room to accommodate for when they have the case. And also very limited support for the transferring care home to the health system. Next slide, please. So almost no state guidance for care home. Actually we have available one, but it is emphasis on older person who stay at home or in the community rather than in the care home. There is another one that they try to draft, the Department of Health try to help Department of Older Person to draft how to taking care of person in residential home. So this one, sorry, I still haven't got the draft on hands. And we have a limited capacity to prepare or manage in many homes. As I mentioned earlier, that there's still lack of PPE, lack of official support, lack of a transferring system. Interestingly, we still have no report of case in care home. This is a good news from Thailand. Thank you.
Thank you very much, Siropan. Thank you so much. And well, one of the reasons why I wanted that presentation towards the end is that clearly the situation is very, very gloomy for many parts of the world. So it's great to hear that despite the fact that the sector in Thailand isn't that different, there are many informal providers, as you said, in different parts of Bangkok. There's a lot of concern about access to protective equipment, about information for care home directors. Despite all of that, because the overall pandemic at the moment has been very limited, and let's hope it stays like that, it's really quite striking that, as far as we can tell, there have been no cases, recorded cases, in a single care home in Thailand. So that's fantastic news.
Yeah, we keep finger crossed.
Well, it's very interesting, isn't it?
Yeah.
Okay, folks, so now it's time for our moderated discussion. And you are hearing a lot from me today, sorry. But I will happily pass on questions to the speakers. In fact, it may make more sense if Lucas, who's been collecting those, himself comes back on screen now and starts passing on some of those questions to our speakers for our moderated discussion.
Hey,
over to you, Lucas.
Thank you, Peter. So we have a few questions. I encourage the participants to make more questions. We'll be happy to have a discussion on them. Alice Ashwell asks, to what extent are comorbidities being recorded? We hear a lot about COVID-19 being given as a cause of death, when in fact the person may have been suffering from multiple comorbidities which are not recorded. Maybe Leon and Adelina could address that.
Adelina, do you want to chat or
one thing that's very difficult to do is to assign causality to anything, to say this is the cause and this is the effect. What we get from the data when they tell us that somebody died with the disease is that they died with the disease. We don't know whether that's what caused their death. We cannot be sure about. And that's why, as many academics will say, that the only way we'll know the true impact will be by looking at excess mortality. But we usually will not have this data until quite later on, and there will be both direct and indirect deaths as a result of COVID-19, and we may never really know fully, unless we did very detailed individual level studies, what was the cause of death. Leon, is that?
Yeah, I think we're too early on in the epidemic to know this. I think what only way we're going to be able to look at this is in a year or 2 years' time down the line, to say what was the expected mortality rate for a home, a district, a region, a province, a state, a country for this period of time. And we would then be able to see the estimated increase in mortality because of COVID. So I think one of the things that's really important to know is that when we're talking about people living in care facilities, many of them are frail. Most of them are there because they've got the comorbidities. So if someone has heart failure and dies during this epidemic, did they die because of the heart failure? Did they die because of, and they're co-infected with COVID? I think it's a moot point. I think what we need to do is to say the most vulnerable population during this condition are the older people, older adults living in care facilities. And that doesn't mean because they're old and they're frail, got comorbidities and are potentially going to die in the next 6 months, that we should sort of do nothing because, well, so what? So a disease comes along and accelerates the death. We just put our arms up and say, well, we could have done nothing about it. the impact of the disease is enormous. It's impacting on care workers. It's impacting on the cost of running facilities. It's impacting on families. It's impacting on everyone. And we really do need to come up with some decent solutions to this. And how many people are going to die extra from this? Well, maybe it's going to be 10%, maybe it's going to be 20%. Maybe I've seen some studies that have come out from Italy that the average age of death of people dying from COVID is 79, and the average life expectancy in Italy is 82. So, younger people throw their arms up and say, well, why should we restrict our lives? Why should we stop our activities? Why should we stop why should we come to a complete economic standstill because of this? And I think, these are important questions to answer. They're societal questions. I don't have an answer as to, are there people going to die from comorbidities? Are they going to die with COVID? What I do know is that this is having a significant impact on society. It's having a significant impact on older people. And either we're going to take a stance and say older people actually are relevant and they do have a role to play in society, or we're going to turn around and say, well, you know what, you're 79 years old, you're 80 years old, you're 85 years old. So what, you've lived your life. Why should we restrict your life for a younger person? And I don't know if that's the society I want to live in.
Very good. Thank you, Leon. The following question is an interesting topic raised by Bridget. She says, I've learned this week of a situation in which 2 residents were discharged from a hospital to a care home using the same transport ambulance, and cross-infection occurring for the resident who did not have the virus prior to the situation. So the question is, how can we raise awareness of risks? How can we empower individuals to challenge such practices? Does anyone like to answer to address the cross-infection and raise awareness, empowerment of individuals?
I think that, sorry, no, Leon, please shoot.
Yeah, it's a discussion I had with our local Department of Health this morning in terms of how do we start educating? What sort of education programs are out there? Education programs within facilities who are providing care. What do care workers know about how this is spread? Are we going to be able to have an impact on the virus by educating people? So I think it is about education. I think clearly if 2 people are being transported in the same ambulance, it doesn't make sense to do that, but then there's limited resources, and how do we cope with it during limited resources? I think one of the other things that's really important that Adelina raised was in older people, they do not have the typical symptoms of coronavirus. They don't have coughs and temperatures and sore throats and runny noses and shortness of breath. Many older people have shortness of breath anyway. Many older people have coughs anyway. But then they suddenly become confused. Last week, my personal experience is last week I went into quarantine because I was exposed to some of the coronavirus, because I got called by a caregiver to say, well, the patient was just more confused than usual. But this is a man with advanced dementia in his late 80s. I went to see him and then suddenly discovered he had a temperature. When I took his temperature, and they tested him the following day, and he was COVID, he was corona positive. I wasn't wearing PPE when I first saw him, and we obviously have to get very close to patients and expose ourselves to it. Now there've been patients admitted to acute care hospitals with just confusion and assumed UTIs, a delirium. Now that's not coronavirus symptoms, but they're getting into hospitals. The question is, how do we upscale our testing? How do we upscale and move from just symptom screening to testing? And, should testing be freely available or widely available in facilities?
Can I just add a rider to what Leon was saying, that certainly in Brazil, we've seen data that show that the leading cause of hospitalization of older people in normal times, not during coronavirus, is poorly managed urinary tract infections, UTIs. And one of the main symptoms of that, of course, is a high temperature. And this just shows the importance of maintaining those other health services for older people in the community setting. Because Firstly, they will be presented as suspicious cases for coronavirus. Secondly, they will be going to hospitals, which in the present situation are extremely dangerous places for them to go to. And often this happens because they were not treated in the community in the first place. They either lacked hydration, or their hygiene was not maintained, or they didn't get antibiotics that they required to control the infection at an early stage. So this just shows how we need to see the bigger picture here. And this is also the case in care homes. One of the major reasons for older people being taken out of care homes to hospitals before coronavirus were things like poorly managed urinary tract infections.
Very
Would
good.
any of the other speakers like to respond to these questions?
I have a question for Adelina. Camila asks, are countries holding daily briefings on publishing daily figures on cases or deaths, including care homes? And he mentions a recent change in the UK about giving more information about that. Can you share with us?
Yeah, so the first country to do this was France, as far as I know, at the end of March. And in just one day, they increased their death figures by 3,000 by including suspected deaths in care homes. And that was the first country that was open and that said, actually, we test all these people, but mostly in hospitals, but we're missing all these people that are dying in care homes mostly without testing. Then a few other countries, Belgium, Ireland, started to provide these data, and the UK has only just started doing that now too. There's also countries where they can't agree between the different regions how to do this. So in Spain, each region is collecting the data differently, and they're having, so they have a lot of difficulties with coming up with the single numbers. And so there's all sorts of situations in different countries, different contexts, different administrative issues. As we have said before, there's not very clear responsibilities for long-term care in most countries, not even high-income countries quite often. So it's very confused, the picture. And I would say that in most countries, it's fair to say, in most high-income countries that have experienced COVID, except countries like Hong Kong, Singapore, South Korea, that had experience of SARS and MERS. In most of the countries in Europe and North America, care homes have been an afterthought in terms of planning for the epidemic.
Lucas, can I address an issue over here as well? One of the issues that I'm concerned about as well, and it's really just a theoretical concern at the moment, is that because of coronavirus, people living in care homes are not going into acute care facilities. So people are going into heart failure, having worsening acute conditions that they would on chronic conditions that they have. And these are not being dealt with properly because of the fear of sending people to care to acute care services or getting hospital or doctors into the facilities. So it will really be interesting to know how many people are being not treated for their chronic conditions properly because of the fear around COVID. So there's a double-edged sword here. It's deaths because of COVID, and then the unintended consequence of people with the chronic conditions not being treated properly because of COVID, and fear of what's going to happen if we do treat them in different ways.
Very good. Leon, there is a question you would like to answer live about the survey.
For me, yes, I would love to do a survey like this. And I think from what we've seen from the Argentinian survey, it would be great. Peter, I'm not sure if you're able to translate the questions, or if someone's able to translate the questions. It would be really great to be able to duplicate this survey globally amongst many care homes and get the input and find out what's happening in facilities. And it makes for a really fabulous case study of what's happening globally.
And I will pitch in, Femada Shaman also asks, how can this platform be used to learn about creating a network for care homes in low and middle income countries? I would like to raise the point that Adelina is leading LTC, and she's willing to include more information on the global south. So it's a very good opportunity also for Adelina to gather more data and to share with other countries, right?
I can say quickly that I think there's even some people in this call who are currently preparing to provide one of some country reports from low and middle income countries for LTC COVID. These documents are very much a collaborative effort, and people are contributing. Quite often what we have in a country is that one or two people start the document and then others join and contribute, and the documents are regularly updated and expanded. This is all running on goodwill, and we're very, very happy to hear from more people who'd like to join and provide information and contribute. I also understand that, and that's quite a different level. So LTC COVID operates more in terms of sharing information and resources and sharing reports, but there may also be some other forms of communication. And then in England, there's some very good WhatsApp groups of care home managers sharing information, more practical information about how to tackle the condition. And it may be that there's also an opportunity for using social media in other more flexible and rapid ways. Don't know if this is a good forum for thinking about this, but it's something that may also be helpful.
I have a question to Siripan. Have you seen cooperation, Siripan, between health and social care agencies? And it's the same question, very similar to Argentina also. So Nelida and Siripan, have you seen cooperation between both sectors? Who would like to start?
Right. Can I start?
Yes, please, Siripan.
Yes, I mentioned earlier that there was one guidance have been produced by Department of Older Person who oversee residential home, public residential home throughout the country. They receive support from Department of Health, Ministry of Public Health, help them to draft the guidance and ask them to apply. They also have the award. They give the award to the care home who follow their instruction properly. So this is a quite starting point of the cooperation between health and social. Yes,
very
that's
good.
all for me. Yeah.
Thank you, Siripang. Nelida? Sorry, I will unmute you. Okay, now, Nelida?
Yes. Yes, in Argentina, at the national level, the health experts are leading the cut down and the strategy. But in local levels, yes, there are participation from social services and health services, but are not well articulated, I suppose, because from one part is social services asking for voluntaries to visit older persons, and the other side is the health ministry. It's not linked at all. It's not a socio-sanitary approach. Is both carry out together, but not articulate in the local level, not in the national level or provincial level.
Okay, very good. Thank you so much. I think we covered most of the questions. I apologize if some of them couldn't be answered. We'll keep having more sessions and we could include more questions and answers in the future. Thank you so much. Peter?
Thank you to all the speakers, to all the people who are participating in the webinar, and especially thank you to Lucas, because he's been very brave about the fact he's actually got a really bad migraine today, and he's still been managing this webinar with a bad migraine. Just a couple of last points. If you can go to the next slide, please, Lucas.
Just a second.
Thanks. Just a couple of forthcoming events. On Monday, the global platform will be trying to bring together a diverse set of people to see if there is some value in establishing a new global group with an interest in ageism and coronavirus. And that comes out of a webinar which we ran on the 24th of April. These are the times, and this is now on our website as well, if you want to join in those Zoom conversations. So they will be taking place 3 UK time and 5 UK time. Because not everybody can manage all of those times. So there's more information about that on our website. Next slide, please. Next webinars we have coming. Next Friday, we'll be looking at lockdowns and older people in low and middle income countries. We have speakers from Help Age, Human Rights Watch, and a number of different countries. And then on the 15th of May, we have a session on pensions, social protection, and older people in low and middle income countries. So if you're interested in those, please do register for them on our website so that we can plan in advance. And next slide, please. This is the last slide in the webinar.